Thank you very much. Can everybody hear me? Is that working? Yes, it is. Great. Thank you very much, Dame Sally Davies, for a really excellent introduction, I think, to many people to the developments in the way that you're working to look at patient needs and patient involvement in the UK. It picks up on a lot of the things that we discussed yesterday, and maybe this is a good time to share some of them briefly with you. We recognise that for a system to be truly universal, it does need to provide equitable, high-quality access to healthcare. We mentioned and explored a lot of the barriers. Some of them were common, some of them were much more stark realities in different regions to others, even to the point of discrimination still being a massive barrier to any access to diagnosis or care in many situations and many countries. Some of the things that resonated in what you were talking about, and I think were key in many of the discussions, were the question of how we really do refocus on the patient. So you mentioned a patient story, where somebody said, actually, it's about, living a life that's satisfying to me. That's what I want to be looking at. And yesterday we were talking about how we refocus all of this on the aspirations of people, and not on, how I improve the management of my care, how I have just a better health outcome, recognising, the WHO's definition that it's really quality of life as well as care. So I think that's still a whole shift that we need to make, and that was very much at the centre of one of the themes that we looked at. The other themes we looked at were equality, quality, accountability and standards, and patient role in that, the value of healthcare and not the cost of healthcare. And I think, again, you were talking about health and wealth, and often we just look at the burden and the cost. We don't look at having a healthy population and a healthy workforce being saving us money. The reorientation of the system to be patient-centred, patient empowerment, communication, education, engagement and collaboration, and many of those themes you brought up. We would like to open it up to some questions from the audience. Many themes have been raised, so I can see quite a few hands shooting up. I'm going to start this side of the room, so with Wim and then Robert, and then we'll move over that way. Thanks.
Thank you. Wim Wientjes from the International Diabetes Federation. Wonderful talk. I'm very interested in conflicts of interest. So I'm very interested what on your, I don't know the good English word, on your towel, what is written on it?
I wish I knew, actually. I was given a scruffy sling that didn't work, and this was a present wrapped around some Korean sweets from a mother of one of my daughter's friends. So if there's anyone Korean who can tell me what it says, I'd love to know.
We'll do that in the break. I think we can have that translated when we go for the coffee break. So next question.
Sally, thanks very much. Robert Johnston, I'm on the board of IARPO, and I came up through National Voices to that position, so I'm UK-based. Very impressed with what you said. Really like what Involve has done over the years. I was active in Involve until about 5 years ago, so very impressed and seen it from the inside. What I would like to see is a similar sort of initiative to train patient leaders, and really, not just in research, but in every aspect of the production of healthcare, to train patients up so that they have the skills and just as importantly, the confidence to engage with clinicians, to engage with economists, to engage with managers of healthcare. And we need to do that before we initiate it. We need to bring those people on so that they can actively participate and improve things. I also wanted to say that one of the things you mentioned in there was only 9% were interested in research on drugs. A lot of us with chronic conditions derive an immense amount of benefit from things that are not drug-related. So, for instance, complementary therapies. And I think one of the roles that the NHS can fulfill with its research is to focus more into those areas. One of my local commissioners was telling me that he was prepared to do some experiments with acupuncture. And he had found that with knee replacement for osteoarthritis, he offered people acupuncture before they had the surgery. And he found that 70% less needed surgery. But then the funding ran out, and he couldn't do it anymore. And there was prejudice in the system which said, but acupuncture's weird. You know, you can't do that within the NHS. So it's those two issues. One is training patient leaders and preparing them for a more active engagement in the system. And the second, I think, is focusing more on non-pharmaceutical research. Thank you.
Thank you very much. Thank you. Yeah, I've got it on, Robert. I agree. It would be my dream to see Healthwatch, who I think are the responsible body, develop patients and the public more generally in the way we have done for research, and I think that would be wonderful. So I hope they do. On the complementary therapies, I do agree with you. I can see an argument for why most of them would work apart from homeopathy, and we have funded a considerable amount of research in those areas, both acupuncture, quite a lot around different holistic approaches, because no one else does. And we need to know whether they work and whether they're cost effective. So we will continue to. But we do need high quality applications. What we've done to improve the applications is put in place in every region in England a research design service to help people who've got good ideas but aren't used to working up design research applications, to help them put together a winning application. And their funding depends on success, so they have an interest in the outcome.
Hello.
I think, sorry, could I just ask you to wait a minute? We'll take 3 questions. So Evelyn, and then I saw Rosemary, and Jonathan, I think, was next, and then we'll come back.
Hi, I'm Evelyn. I come from Venezuela. I represent the Venezuelan Federation of Associations on behalf of persons with intellectual and psychosocial disabilities, their families and their caretakers. And but I also am the vice president of a junior college that trains special educators. And in the research that they do as part of their in order to graduate as a requirement, I would be extremely interested in applying the PPI plan and get some information about the PPI plan. I think it's important for them to really get involved. Regardless of their cognitive compromise, I'm sure persons with developmental disabilities can be involved in this kind of research because they are the most down to earth and they have a lot of common sense, and they're going to be the ones getting affected. Also, I was wondering whether physicians in their training programs, when you graduate physicians in the ethics subject or whatever other subject, they also get some kind of training regarding the importance of the PPI planning, and also because in countries like in general, in Latin America, physicians do not respond to patients' questions. They figure, listen, you don't know what you're talking about. You're just getting information out of the internet and you don't know what the sources are. I know, I'm the specialist. I'm the one who knows what's going on. Therefore, don't ask. So I was wondering if a campaign that says, go respond, would also be a good campaign, because really, patients ask. It's just that they don't get the answer. They should. And that was just a comment. And thank you for a wonderful presentation. Thank you.
Thank you, Evelyn, and Rosemary, and then Jonathan. And if I could ask you to keep them quite short so we can get as many questions as possible in the limited time. Thanks.
Thank you, Rosemary from the Arrhythmia Alliance. Very pleased to hear, Dame Sally, that the emphasis is on research. I would question the effectiveness so far of Healthwatch locally. And if you want me to tell you over coffee, I won't go into it now. And but my question is, you said that you want to harness NHS research to improve health and increase economic growth. We raised concerns yesterday about access for groups like the elderly, where it's much harder to make the argument about externalities with, economic benefits for the whole of society. So I'd like to know what plans you've got to deal with an ageing population and the problems that you see with that, please. Oh, yeah, sorry.
Thank you. I'm Jonathan Tritter. I'm an academic, and I've been working on patient and public involvement as my main research interest for the last 15 years. And I'm thrilled with the developments in NIHR. I think it's a really excellent thing. I've been involved myself. I do think, like Robert said, the need to find ways of finessing people who are actively involved in research and people who want to be involved in organizational and system development and indeed policy change is a really important phenomena. And I think HealthWatch is a really weak mechanism. And in part, that weakness is about the lack of accountability to the public for commissioning and how that's disarticulated from the development of a joint strategic needs assessment, in that the commissioning relates to the public but not to HealthWatch under the legislation. And partly there's a need to develop JSNAs so they actually do have a mechanism for identifying the priorities for health provision from the perspective of patients and the public. And the final issue is really what's the difference between patient interests and public interests, because most of these are elided. And actually, I think they are distinct. And we should think about those times when we should engage with the public as citizens, and those times we should engage with patients as experts through experience, and not consider these as synonymous.
I think I'm on now. Thank you very much. What a set of questions. Evelyn, you can have a PPI plan with people with learning disabilities. We expect that, and I think you could reasonably build on the type of models we've used. And I invite our deputy chair to stand up and wave at you all so you know who to talk to if you want more advice than is on our website. And you picked up postgraduate training. I have a daughter who's at home from university at the moment who's in the first year of medicine. And when I came home on Friday from the hospital, I said to her, it has changed how they're treating patients from when I was a young doctor. I was asked much more what I wanted, did I feel all right, and all sorts of things. And she said, oh, Mum, they teach us that in medical school. So I think they're doing it in medical school as well as postgraduate training, and it's about communication and treating people decently. I'm sure there will always be ones that don't get it right, but clearly we are making strides. I could tell you funny stories of my interactions with young doctors that don't get it right, actually. It's always good for me to be on what I call the wrong side of medicine. When we talk to the issues that Rosemary brought up about the elderly, clearly what we are concerned for is to make sure that people age with dignity and the best health they can have, and that their carers are supported in the best way possible. So we fund quite a lot of research into dementia, as I mentioned, about carers and the best ways of going forward, and quite a lot of diseases or chronic problems that affect the elderly. So I absolutely recognise what you're saying. And then, Jonathan, let me just agree with you, for all I allied patients and the public as I talked, I absolutely recognise and agree with you on the distinction between me as a citizen, me as a patient, all of us as we play out different roles. And we can, each of us, be each of those different things at different times. We should not allow anyone to be pigeonholed in one for good and always. Thank you.
We've got time for one more quick round of 3 more questions. So I think we've got Bejan and Origit I saw, and I'm looking for another hand. There's a hand there that I can sort of barely see. Monica, great. Yeah, Bejan, Origit, Monica, please. And please, could you keep them very short and to the point? We're sort of out of time, so we're...
Professor Davies, I'm Bejan Mishra from India. working on patient advocacy activities. In 1999, I had the opportunity to study ombudsman in the healthcare in UK. British Council were kind enough to make me come here and study that. And in the 15 years, I find that there has been an immense change out of your presentation. What I was really looking at is that when you talk about value for money for patients, how do you ensure that what you have promised, if you have not delivered, how do they get back that value which they have paid for? Number one. Number two, I also wanted to understand in terms of how do you make all these services more accountable and transparent to the patient, and what are those mechanisms which you have adopted to document in terms of and share with us who are learners in this, because we will take back this knowledge back to our country to use it rather than reinventing the wheel, because you've already done it, so we want to take it back. So I would like to understand from you, what are those mechanisms you are adopting to ensure that the patient gets what they want or they're expecting out of you?
Thank you. Just quick questions about, I'm Arajit from Heart to Heart Foundation, and I also work with the National Health Security Office. Maybe you acquaint with our office as well, because we apply your model from NHS to the universal health coverage in Thailand. Just ask about the patient involvement. Since the universal health coverage system in Thailand, we also have patient and NGO sit in our board, and it helps a lot to develop the policy and system. And just ask about the patient involvement in the sense of they can involve in the benefit package development in order to cope, to respond to the need of the patient. Right now, we have some kind like autistic people or Down syndrome people or CP shy, and they have their parent to involved in the how to, they can come to the hospital and they can get advice from the professional, and then they can also provide their experience in the hospital with the professional. So in this approach or in this way, what do you think that is better for the efficient service for in the healthcare service? Thank you.
My name is Monica Kendall, and I represent people with epilepsy in the southeast. I would like to know, because it's a chronic disorder, how they can be expected to set themselves back for many, many years if, should a seizure occur, their driving license is taken away, perhaps their ability to continue working would also be taken away. And I consider this to be really serious, and I would like to know what you have to be able to identify and assist.
Thank you.
Especially even if the drug is changed in the manufacture, again, they could be at risk.
Let me go in reverse order. Monica, I think you've asked me something out of my specialist expertise. I'm a hematologist. What I agree with you that seizures do set people back, but clearly people are stopped from driving in order to protect not only themselves but other people. So I don't know how to get into that one for you. I'm sorry. And so in my annual report published on Thursday, there's a chapter about how employers can help their employees and how important it is. So I have asked one of my deputy chief medical officers to lead on work and employment and working with employers. So Orijit, let me just say that I think Thailand does extraordinarily well on public involvement, your board and everything. I think we have things we can learn from Thailand. So you should talk to all my colleagues here. What I would say that in developing the package of benefits, we do that essentially through using our National Institute of Clinical Excellence, who define what are the standards and what should be used, and the guidelines, and they do involve public and patients in their panels that make those decisions. So we do it through an arm's length body called NICE, but I love the way you do it with your board and everything over in Thailand. Baejon, I wish I could give you all the answers that I think we should be able to give you. The Health Ombudsman has played a very important role and continues to. But I think we have a healthcare system that is not as accountable as it should be. And it isn't because we've gone to a commissioner-provider model, which while in the purity of the McKinsey and consultant mind is very beautiful, can only work and deliver accountability if the commissioners actually know what they're doing. And they are on a perpetual learning curve, because with every reorganization, we seem to get new people. So the accountability is not as strong as it should be. One experiment by our previous government was to have councils, or somebody else will know the word, for foundation trusts to hold them to account. And I think that, thank you, members, yes. And I think that could play a role, and I have seen it give hospitals a bit of a bad time from occasionally. But it's no way as good as it should be. If you have that separated role, the commissioners ought to be checking the accountability on behalf of those for whom they commission, the public and the patients.
Thank you. Great questions, and I think your presentation has sparked a lot of ideas, and really this is what the Congress is all about. It's sharing different models and thinking, would that work? Does that help us? Is that terrible? What can we do? I'd like to ask Sally if you have any other comments you'd like to leave us with for today.
Well, that was quite a set of questions after a shorter night than we're all used to for Saturday night. I would just say that I very rarely do anything work-related at the weekend, and I came because I care about this. I think it is very important that we find ways to get public and patient involvement, and that we increase accountability of all bits of the systems, not only in Britain, but everywhere. I have just gone on to the WHO Executive Board, so I will take my values into the Executive Board. Thank you.
So a very, very big thank you from all of us. I have a few housekeeping announcements just to make before we go. First of all, if anyone wants to change their shuttle bus for tomorrow, please let the registration desk know today. Secondly, we're going to take the opportunity, it's not raining, and have a group photo now. So we will all be led out onto the lawn to have a group photo. Then after that, coffee and tea will be served in the bar out here. And then at 11 o'clock, we have our first stream sessions on equity, quality and financing. And details of the sessions are in the handbook. And then lunch will be at 12:30 in the Hyperion restaurant upstairs, with the second stream sessions from 1:30. So have a really good day. Thank you.